Good morning. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. So please don't forget to subscribe my channel and also please give your valuable comments. So we have been discussing about interpretation of the CBC in the clinical practice, especially in childhood clinical practice. So last class we have seen one of the case, and which is basically an iron deficiency anemia. So today we will have another case. We know that in case of iron deficiency anemia, what is the finding? Iron deficiency anemia, we will have raised, that means increased RDW with the decreased MCV. That is very typical, but it has to be differentiated from thalassemia, and that we have already studied. Today we will have another important case, that is case number 2. So let us discuss about this case first. This is actually a 3-year-old male child, with a history of the pallor, fatigability, and as well as history of a pallor and as well as fatigability since last 1 month. So child is having this fatigability etc. since last 1 month. Child is also having jaundice for last 15 days. For having the jaundice for 15 days. Child had the jaundice for 15 days. पहले उसको jaundice हुआ था 15 दिन तक, और अभी जो है बच्चे को वो pallor है, fatigability since last 1 month. I think child is having jaundice, but अभी है उसको jaundice since last 15 days. And there is also recurrent stomatitis. And child is also having pallor plus on examination. On examination, child is having pallor plus. Icterus is also present. Stomatitis is also present. And the liver and spleen are not palpable. And there is no lymphadenopathy. So this is the case. Now can you come to a conclusion by this much of case? क्या हो सकता है? 3-year-old child, मेल चाइल्ड है, पेलर है, फैटिगेबिलिटी है लास्ट 1 महीने से, जॉन्डिस है 15 दिन से, और बच्चे को रिकरेंट स्टोमाटाइटिस है. सो पेलर इज प्लस ऑन एग्जामिनेशन, ठीक है. इक्टरस इज ऑल्सो प्रेजेंट एंड स्टोमाटाइटिस इज ऑल्सो प्रेजेंट. स्टोमाटाइटिस मुकापाक है उसको. ऑफ कोर्स लिवर एंड स्प्लीन आर नॉट palpable and there is no lymphadenopathy. Any idea? So basically in one of the class I explained there are basically 4 types of anemias, maybe the first videos. There are 4 types of anemias: deficiency anemias, hemolytic anemias, bone marrow anemias, and as well as hemorrhagic anemias. Now if you look into this picture, to which particular category it comes? Do you think it is a deficiency anemia? Deficiency anemias develop very slowly and the child remain active. Okay, hemolytic anemias will have anemia and there will be liver and spleen most of the time, and some other symptoms will be there. Hemorrhagic anemias means there will be always a history of hemorrhage, like worm infestation or occult bleeding, melena, hemorrhages etc. or hemorrhoids etc. Bone marrow anemias, we will have a sick looking child. Now by looking at this thing, so which type you want to include? Child is also having the jaundice for 15 days. When I have got jaundice for 15 days child, this jaundice may be a conjugated jaundice or unconjugated jaundice. We don't know, much information is not available. If it is a conjugated jaundice, okay, there may be some pathology where RBCs are abnormally destroyed. Okay, if there is conjugated jaundice or hepatic jaundice, what we say, then the liver is not able to convert the unconjugated bilirubin into bilirubin, and that may be leading to this problem. Okay, so that means it may be unconjugated or it may be conjugated. If it is conjugated, the problem is not with the, if the conjugated is increased, or it may be unconjugated, which may be get increased. Anything is possible. That means, I mean to say, it may be a RBC pathology or it may be a liver pathology. Icterus is anyway present, and stomatitis is present, of course. There is a stomatitis. Mucopaka is also present. There is no any lymphadenopathy. So when there is no lymphadenopathy, okay, some of the infective pathologies are excluded. Now let us look into the reports. See, this is the report. The report is showing this particular picture. HB is 5.6 grams. MCV is 110. And MCH is 23. MCHC is 24. RDW is 26. And RBC is 2.3. RBC count is 2.3. RBC count, we know that how much? It should be 5 millions. But it is 2.3. And RBC is macrocytic and ovelocyte. RBC size is abnormal. And if you look into WBC, now this is quite interesting. WBC is 2800. WBC is decreased. Polymorphous is 62, lymphocyte is 38, and platelets are 80,000. Platelets are 80,000. Now platelets are also decreased. WBC is also decreased. So this is the blood picture now. Now you have to give a conclusion on this. Yes, anybody? Yes, anybody can answer for this question. Are you able to hear me?
Yes, sir.
Yes, कुछ comment करो इसका बारे में, what it may be. If you want to see the history, I will again explain it. HB is 5.6 grams. MCV is 110. What did it suggest?
MCV is the
MCV is normal MCV is 90. Instead of that, MCV is 110. That means yes, the space occupied by the single RBC is now more. That means it is not normocytic, isn't it? वो ज़्यादा space ले रहा है, इसका मतलब है उसका size बड़ा है. So it is macrocytic. So MCV is 110. It's okay. What about the MCH? MCH is 23. Normal MCH is 30. Normal MCH is 30, but it is 23. That means mean corpuscular hemoglobin that is decreased. MCH is decreased. इसके अंदर जो hemoglobin है वो कम है. Yes, MCHC is 24. Hemoglobinization का जो percentage है, that should be 33%, but it is 24 again. It is 24. That means hemoglobin is no doubt it is decreased, but RBC size is increased. RBC size is increased. So it may be a macrocytic. Okay, the RBC size is abnormally increased. It may be macrocytic. Now this much is okay. Now come to RDW. Red cell distribution is 26. RDW is 26. Normal is about 14 to 17.
5 to 14.5.
But now it is 26. That means red cell distribution is also, width is also increased 26. Now red cell distribution width increases in two conditions. In the last class we have seen. Anybody can recall?
iron deficiency anemia with decreased MCV or normal MCV के साथ sickle cell और malignancy में.
Some of the malignancy it may increase. So RDW is increased. Now here MCV is also increased and RDW is also increased.
Megaloblastic anemia.
Maybe yes. Okay, because megaloblastic anemia is also nothing but it is a macrocyte only, abnormal shape of the cell only. Okay, so macrocyte only. Now this picture is now MCV is 110, MCH 23, MCSC 24 and RDW is increased now. Increased RDW with the increased MCV is suggestive of megaloblastic anemia. Okay, तो उसके अंदर जो hemoglobin है उसका concentration तो कम है इस picture के अनुसार. Now come to the RBC. Now they are telling that RBC size is decreased. The RBC number is decreased. RBC is 5 million, that is only 2.3. Okay, that is only 2.3. That means now the production of the RBC from the bone marrow itself looks affected. Bone marrow कितना RBC को produce करना है उतना प्रोडक्शन नहीं कर रहा है, ठीक है, इसलिए आरबीसी का नंबर कम है, ठीक है। अगर बोन मैरो ठीक से आरबीसी को प्रोड्यूस कर रहा है, ठीक है, तो उसका नंबर सही होना चाहिए। अगर आयरन कम है तो हो सकता है कि माइक्रोसाइटिक हाइपोक्रोमिक हो जाए आयरन का कमी की वजह से, बट यहाँ पे वो वाला पिक्चर नहीं है। द पिक्चर हियर इज आरबीसी इटसेल्फ इज डिक्रीज्ड। इट लुक्स दैट आरबीसी का प्रोडक्शन ही जो है यहाँ पे डिक्रीज्ड है। सो मे बी समथिंग रिलेटेड टू बोन मैरो ऑल्सो, आई डोंट नो। नाउ कम टू द नेक्स्ट पिक्चर, WBC। ओके, पेरिफेरल ब्लड स्मीयर में क्या है, आरबीसी इज मैक्रोसाइटिक। हाँ, वो तो जब एमसीवी बढ़ा था तभी हमें समझ में आ गया था, डेफिनेटली आरबीसी इज मैक्रोसाइटिक और मेगलोब्लास्टिक, and there is ovelocytes, some abnormal cells are also there, okay, in the peripheral blood picture, not only macrocyte, some other ovelocytes, oval shaped RBC bhi hai, okay. So this is about the RBC cell line. So we have seen the RBC cell line. Now look into the WBC cell line. Now if you look into WBC cell line, WBC is 2800. So WBC is extremely low, isn't it? WBC is extremely low, 2800. Polymorphous 62 hai, lymphocyte 38 hai. WBC is 2800. So there is some problem with the lymphoid cell line also, है ना। WBC cell line के साथ भी कुछ कमी है। And if you look into platelets, platelets are also decreased. Platelets 5 lakhs के आसपास होना चाहिए. It is only 80,000. That means even the platelets are also decreased. Platelets are also decreased. Now the picture is very clear. We have seen all the three cell lines. We have seen the RBC cell lines. We have also, that means myeloid cell series, we have seen the lymphoid cell series, and we have also seen the granulocytes or platelet cell series. Okay, so now platelets are also decreased, WBC is also decreased, and RBC is also decreased. So there will be cytopenia, total cytopenia, pancytopenia is seen according to this particular finding. Okay, so जब तीनों cell line जब कम हुआ है, so definitely there will be some problem related to bone marrow. There will be some problem related to bone marrow itself, bone marrow aplasia, या some other malignancy, whatever may be the case, we don't know. But according to the history now, if you go, history says 3-year-old male child. Okay, 3-year-old male child, and pallor is there, fatigability is there, 1 महीने से चल रहा है, and jaundice is there for 15 days. Okay, recurrent stomatitis is also there, pallor is also there, and liver spleen is not palpable. Okay, if there is a problem with the bone marrow, liver and spleen are not palpable in the initial stage. In the later stage, it may be palpable. Otherwise, it is not palpable. Okay, in a pure bone marrow disease, because liver और spleen से कुछ करना ही नहीं है. Liver spleen क्या करेगा? Spleen तो abnormal RBC को जो है वो destroy करेगा. बट जब आरबीसी का प्रोडक्शन ही नहीं हो रहा है तो स्प्लीन के लिए कुछ ज़्यादा नहीं है तो वो बढ़ेगा नहीं. ओके, सो देयर इज ऑल्सो नो लिम्फेडिनोपैथी. सो मे बी इट इज ए डेफिशिएंसी प्रॉब्लम और मे बी इट इज मे बी द बोन मैरो इश्यू. सो कम टू द नेक्स्ट स्लाइड नाउ. सी, दिस इज दैट पर्टिकुलर केस. इफ यू लुक इन टू दिस पर्टिकुलर पिक्चर हियर, इट्स वेरी क्लियर. दिस पिक्चर इज क्लियरली सजेस्ट दैट देयर इज ए बाल टंग. ठीक है, दिस इज अ 3-year-old मेल चाइल्ड. ओके, केस 2. तो पिक्चर शोज क्लियरली सजेस्ट द बाल टंग. बच्चे का जो टंग है वो बाल टंग है, एंड शाइनिंग टंग, बाल टंग और शाइनिंग टंग, एंड देयर इज अ हाइपर पिगमेंटेशन ऑफ द डिजिट्स. इफ यू लुक इनटू द डिजिट्स, सेकंड पिक्चर एंड थर्ड पिक्चर, डिजिट्स में देखो देयर इज अ हाइपर पिगमेंटेशन, स्पेशली इन द डिजिट्स और नकल्स विद अ शार्प डिमार्केशन. वेरी शार्प डिमार्केशन इज देयर. पैर वाला है ना, वेरी शार्प डिमार्केशन इज देयर. So this is a clinical picture we have got, along with the pallor, fatigability, and jaundice, icterus, etc. Now analysis you do. Yes, patient is there with the pallor, and also there is fatigability, and then jaundice, etc. is also there. So this may be a progressive disorder. Okay, पहले patient को pallor हुआ और pallor की वजह से उसको fatigability हुआ, और pallor अगर हुआ है कुछ आरबीसी ज़्यादा डिस्ट्रॉय हो चुका होगा और इसकी वजह से ज़्यादा अनकॉन्जुगेटेड बिलिरुबिन बन गया और वो कॉन्जुगेट हो गया तो उसको जॉन्डिस आ गया. सो समथिंग इज़ वेरी क्लियर दैट दिस इज समथिंग प्रोग्रेसिव. धीरे धीरे एक स्टेप से एक स्टेप में बढ़ता जा रहा है ना. पहले की पेलर था, फैटिगेबिलिटी था, और उसके बाद जॉन्डिस आ गया. अब हो सकता है कि आगे जाके उसको स्प्लीन भी बढ़ जाए, पता नहीं. When the jaundice is there, now we have to think about the liver disease. Obvious. If there is only pale hair is there, then we can think about deficiency problem, bone marrow problem, or hemorrhagic problem, etc. But when the jaundice is there, definitely we have to think about the liver. Liver may not be able to convert the unconjugated bilirubin into conjugated bilirubin. That may be the cause. Or liver itself is diseased, therefore it is not able to convert. Number one is the load is more, therefore usually liver convert 6 to 7 times more than the normal capacity. Conversion जो है, conjugation जो करता है liver, it is 6 to 7 times more capacity. When that capacity is also exhausted, okay, so then there will be increased unconjugated jaundice or unconjugated bilirubin in the blood. That's one issue. Or if the liver itself is damaged, it is not able to convert the unconjugated into conjugated itself, that is another issue. Okay, so when the jaundice is there, we have to think about some of the liver disease or due to some hematological other conditions like over RBC destruction, etc. Now ask whether the child passes the dark urine. Now you have to ask one question with the child here. Whether the child passes the dark urine. If the child is passing the dark urine or polyurine, so then it is a liver disorder and there will be hyperbilirubinemia. That means dark urine अगर pass कर रहा है, so that suggests conjugation हो रहा है उसका, है ना, conjugation हो रहा है. तो conjugation हो रहा है तो ज़्यादा urobilinogen बन रहा है, ज़्यादा urobilinogen बन रहा है तो he is passing dark urine. Okay, so if the liver disorder, ask whether the child has passed the dark urine. If the dark urine is there, then conjugation is happening more. बहुत ज़्यादा conjugation हो रहा है. Maybe unconjugated problem है or anything. अभी इसमें हम कुछ नहीं बोल सकते. Okay, so now come to the next point. If the jaundice is associated with without a dark urine, जो jaundice यहाँ पे है, it is not a dark urine. Okay, वो slightly stained है, yellowish है, not a dark urine नहीं है. It may be either ineffective erythropoiesis or maybe any of the hemolytic problems, isn't it? That means dark urine नहीं है, ज़्यादा conjugation नहीं हो रहा है, तो unconjugated bilirubin बढ़ा हुआ है blood में. तो unconjugated bilirubin जो है water insoluble है, it will not pass through the urine, we know that. So it will not produce a dark urine. But if the dark urine is there, then it suggests it's a conjugated. बहुत ज़्यादा जो है ये conjugation चल रहा है. Okay, now this child is having low HB and as we know that MCV is very high. इसका HB कम है और MCV is very high and RDW is also high. RDW is also high. So high RDW with the high MCV, as already you have told, high RDW with the high MCV, this is always suggestive of a megaloblastic anemia. This is always suggestive of megaloblastic anemia. Basically, this child is having ineffective erythropoiesis. जो erythropoiesis RBC का production ही कम है due to megaloblastic anemia. Due to megaloblastic anemia. So now we have to go for LDH and serum bilirubin and reticulocyte count. Can anybody say the full form of LDH? Lactogen dehydrogenase. Okay, lactogen dehydrogenase. Now come to the next part here. We have gone for LDH. LDH is 5500, which is very, very high. Okay, reticulocyte is 1.2, which is less. Serum bilirubin is 2.3 with a direct only 0.5. So now the things are almost all clear. Direct serum bilirubin is 0.5. That means it is not a conjugated type. Okay, predominantly the indirect type. Indirect type, it's not direct. Direct is very less. Indirect is more, maybe 1.5 around. So therefore, it is basically a hemolytic anemia. That means RBCs are over destroyed or maybe ineffective erythropoiesis. Reticulocyte count is also less, 1.2%. Usually it is more than 2. So reticulocyte count is 1.2. That means more and more mature RBCs are not coming into the blood. Reticulocyte mature RBC माने mature RBCs नहीं आ रहे, माने RBC का production कम है. Basically it suggests that the immediate prior to the RBC is a reticulocyte, isn't it? Reticulocytes, when they are released into the blood, they get mature and become RBC. Now reticulocyte count itself is less. That means bone marrow से जो blood में release हो रहा है वही कम है. The problem may be bone marrow itself is producing less RBCs or less reticulocytes or erythrocytes. So that is also less, and serum bilirubin is 2.3. That is directive, suggestive of indirect type of jaundice. The child with the hemolytic anemia. Now child is having hemolytic anemia with indirect hyperbilirubinemia. Indirect hyperbilirubinemia with a high reticulocyte count. Now if the child is with the hemolytic anemia, बच्चे को अगर hemolytic anemia है और indirect hyperbilirubinemia भी बढ़ा हुआ है, ठीक है, तो उस कंडीशन में यूजुअली हाई रेटिकुलोसाइट काउंट मिलता है. वो इसलिए जैसे हीमोलाइटिक एनीमिया हो गया, ऑटोइम्यून हीमोलाइटिक एनीमिया, वहाँ पे आरबीसी का डिस्ट्रक्शन ज़्यादा चल रहा है. तो आरबीसी का डिस्ट्रक्शन ज़्यादा चल रहा है तो ज़्यादा से ज़्यादा आरबीसी का प्रोडक्शन होगा. ठीक है, आरबीसी का ज़्यादा प्रोडक्शन होगा तो रेटिकुलोसाइट काउंट भी बढ़ेगा. बट यहाँ पे सब कुछ सही है, बट रेटिकुलोसाइट काउंट इज लेस, सो इट इज नॉट हीमोलाइटिक पैथोलॉजी. ओके, नाउ इफ द चाइल्ड इज देयर विद हीमोलाइटिक एनीमिया प्लस चाइल्ड इज ऑल्सो हैविंग इंडायरेक्ट बिलिरुबिन. इंडायरेक्ट बिलिरुबिन क्यों बढ़ रहा है? आरबीसी का ज्यादा डिस्ट्रक्शन हो रहा है हीमोलाइटिक एनीमिया में, इसलिए इंडायरेक्ट बिलिरुबिन बढ़ रहा है. उस कंडीशन है, अगर ऐसा कंडीशन है, कोई भी हीमोलाइटिक एनीमिया का कंडीशन है, मे बी बिकॉज ऑफ कॉन्जेनिटल और मे बी बिकॉज ऑफ ऑटोइम्यून पैथोलॉजीज, then you should have high reticulocyte count. Now this is a typical case where hemolytic anemia is there with indirect bilirubinemia but with low reticulocyte count. So while child with the low reticulocyte count, indirect bilirubinemia increased, and also child is having low reticulocyte count anemia, and this is suggestive of megaloblastic anemia. In megaloblastic anemia, you will find out this particular condition. Megaloblastic anemia, we will have low reticulocyte count because of megaloblast. क्या है कि there is a problem with the maturation of the RBC. ठीक है, so normal there is a erythrocytes are there, then normoblasts are there, then early normoblast, intermediate normoblast, late normoblast. Late normoblast leads to reticulocyte, and from the reticulocyte there is formation of the RBCs. Okay, now what is actually happening here in this case is megaloblastic anemia. So there is a formation of the megaloblast. Megalo means big. Okay, megalo means big. So there is the reduction of the RBC size is not taking place. Okay, now for the reduction of the RBC size, actually what we need is for the reduction of the RBC size, I have to explain some of the important points here now. RBC is basically containing a nucleus, isn't it? So gradually this nucleus will go into disappear and that place will be taken by the hemoglobin. Okay. So ये जो है इसका जो disappearance होगा, and then the hemoglobin come, this chromatin will go off, and so this actually need two important things. So यहाँ पे जो DNA वगैरह ये होगा इसका, I will take one separate class for that megaloblastic anemia जो होगा, that actually requires two important things. One is vitamin B12 and as well as folic acid. If there is no vitamin B12 and folic acid, then the reduction of the RBC size, that is normoblast, late normoblast, will not take place, and there is no incorporation of hemoglobin inside. There is no incorporation of hemoglobin inside. Actually, in this picture, if you are seeing, actually that is happening. This child is having low reticulocyte count. Child is having indirect bilirubinemia. Child is having pallor. Okay, child is having increased RBC distribution width. Okay, so picture is suggestive of megaloblastic anemia. Okay, and this is also suggested by our examination. On the examination, what we have seen in this case is, this is a case. So there is a bald tongue. Okay, and there is also hyperpigmentation of the digits. The hyperpigmentation of the digits is nothing but it is seen in case of a megaloblastic anemia. Okay, so that is megaloblastic anemia. So why it is happening? Because of a B12 deficiency. Because of B12 deficiency. Now, if you look into the patient, the bald tongue is there, and also child is having stomatitis. Recurrent stomatitis is taking place, mukapaka. Okay, because the oral cavity का जो cells है, epithelial cells है, their turning over is very fast. क्योंकि वहाँ पे बहुत ज़्यादा हम काम भी करते हैं ओरल कैविटी के थ्रू, सो टर्निंग ओवर इज फास्ट. तो वहाँ का जो सेल जो है वो टर्नओवर बहुत जल्दी होता है. सेल का टर्नओवर के लिए बहुत सारे मैक्रो मिनरल्स, मैक्रो मिनरल्स चाहिए. ओके, देयरफॉर इफ देयर इज एनी बी कॉम्प्लेक्स डिफिशियंसी, मे बी B1, B2, B3, B4, B12, कोई भी डिफिशियंसी सबसे पहले वो डिपिक्ट होता है ओरल कैविटी में. सो चाइल्ड विल हैव, द पर्सन विल हैव ग्लोसाइटिस और स्टोमेटाइटिस. ओके, सो दिस प्रॉब्लम्स विद दैट. So stomatitis, usually अगर stomatitis हो गया तो हम क्या देखते हैं? So usually we'll say it is vitamin B deficiency. So here also child is having stomatitis because of B12 and folic acid deficiency. Child is also having the pallor, and supporting for that child is also having this knuckle depigmentation. So picture, peripheral blood picture, CBC का जो picture है, so that is showing increased red cell distribution width with increased MCV. That is also suggestive of megaloblastic anemia. Okay, so clinical picture and lab picture both are suggestive of a megaloblastic anemia. So this is jaundice है यहाँ पे. Okay, so there is also the jaundice, but that jaundice is unconjugated type, not conjugated type. That means these megaloblasts which are ineffectively formed, so they are destroyed to some extent, and because of which there is release of whatever HB जो है वहाँ पे वो बाहर आ गया. उसके अंदर जितना भी थोड़ा बहुत HB जो इनकॉर्पोरेट हुआ है वो बाहर आ गया, and that may be leading to the jaundice. That's also a due course of time. उसको 1-2 महीने से प्रॉब्लम है तब जाके इसको हुआ. But the striking problem is pallor is there because there is no RBC formed. Fatigability is there because there is no hemoglobin inside the megaloblast properly, और RBC नहीं है ठीक से. So fatigability and pallor is there. Okay, all the other symptoms are confusing. Okay, this is actually a case of a megaloblastic anemia. Okay, so this is the megaloblastic changes that you can see in the peripheral blood picture. See, these cells जो बीच में है, they are called as a megaloblast. Okay, megaloblast. Okay, see their size, giant megaloblast बोलते हैं हमको. उसका size जो है आप देख सकते हैं, it's a big size. Okay, the hemoglobin is not properly incorporated inside. The nucleus is not completely disappeared. Some of the granules or chromatin networks etc. is there. Totally becomes a bigger size. Okay, actually वो जो प्रोसेस शुरू होने के लिए न्यूक्लियस वहाँ से डिसइंटीग्रेट होकर के हीमोग्लोबिन आके वहाँ पे सेट होने के लिए एक्चुअली वी नीड विटामिन B12 एंड फोलिक एसिड. द डेफिशिएंसी ऑफ दिस टू will lead to this particular problem.